So today we are going to be talking about neonatal sepsis. Neonatal sepsis is the systemic inflammatory response response syndrome, which is out from a documented infection in the first 4 hours of life. But we can also define it as an acute systemic phase response syndrome to an infection in the first month of life, or in general, can be caused by bacteria, viruses, fungi, and protozoa. Then, bacterial neonatal sepsis is the most common cause of neonatal sepsis and neonatal morbidity and mortality as well. So the incidence in the epidemiology is that there are 1 to 8 cases of neonatal sepsis per 1,000 live birth. Then the mortality is 13 to 70% worldwide, and it occurs more in males than in females, and it is more, like I said, so age is premature infants are the most commonly affected. Then we have risk factors. So risk factors, we can have prematurity, low birth weight, which is less than 2.5 kg/SGA. Then we have premature rupture of membranes, prolonged rupture of membranes, chorioamnionitis, sibling sepsis, meconium stained at delivery, need for resuscitation, and we have prolonged labor, which is some of first and second stage of labor. Okay, then we have classification. So neonatal sepsis can be classified in 2 major categories depending on the onset of symptoms. So we can have early onset sepsis, late onset sepsis. That's what we can have. So early onset sepsis, or EOS, is usually presents within the first 72 hours of life, and in severe cases the neonate may be symptomatic at birth, and infants with the early onset sepsis usually present with respiratory distress and pneumonia. And then the source of infection is generally the maternal genital tract, and some maternal or perinatal conditions may have been associated with an increased risk of early onset sepsis. Then the causes or etiology of early onset sepsis, we have group B, streptococcus. Then we have E. coli, Listeria monocytogenes, then Haemophilus influenza, Klebsiella. Then risk factors, we can have prematurity, premature rupture of membranes, chorioamnionitis, maternal intrapartum fever, and maternal bacteria. These are some of the risk factors. Then for late onset sepsis, it usually presents after 72 hours of life. Then the source of infection and late onset sepsis is nosocomial, which is the hospital acquired or community acquired in neonates, usually present with sepsemia. The pneumonia or meningitis, we have various factors that predispose to an increased risk of nosocomial sepsis, include low birth weight, prematurity, and admission in neonatal intensive care unit. Then we have mechanical ventilation, invasive procedure. Then we can also have administration of parental fluids and the use of stock solutions. Then factors that might increase the risk of community acquired late onset sepsis include poor hygiene, poor cold care, bottle feeding, and pre-lactal feeds. Then in contrast, breastfeeding helps in prevention of infection. So that's why it's necessary for you to tell the mothers to exclusively breastfeed the infants. Okay, then for the causes, we can have Staphylococcus aureus, Haemophilus influenza, Klebsiella, pneumonia, viral, or candida. Okay, then we have 4 routes of exposure to infection. So we can have transplacental, which is from the placenta. We have certain organisms which have inherent ability to penetrate the placenta barrier. Then we have those ones which can ascending infection from the vagina and the cervix, with the risk increases if there is a rupture of the membranes. Then we have bacterial colonization or intrapartum. Then we have infection, which may be caused by opportunistic pathogens colonizing the vaginal tract. Then we can also have environmental or postnatal, with people being the main source. Then hospital acquired infection most likely to be antibiotic resistance for hospital acquired. Okay. Then prevention. So prevention is better than cure. So general prevention, like I said, breastfeeding from outset and root contact with many people. That's the general prevention. Then unit design, we can have sufficient space between cots, good ventilation, and ability to isolate. Okay. Then the equipment care is also part of the prevention procedures. Then ideal individuals with individual stethoscopes, suction units, and after each use of the stethoscope, supposed to clean with any cleaning material. It could be hand sanitizer or anything, clean the stethoscope for each patient. Then shared equipment should be cleaned after each use. Like I said, preferably should have disposal attachments. Then you should also avoid humidified incubators, which which they are, because they are haven for pseudomonas. Then if using humidified incubators to maintain temperature of small baby, drain humidifier daily and refill with sterile or distilled water. Then ventilators, how to encourage disposable circuits, which may be expensive, that can be changed weekly otherwise, but this is expensive, but it works. Okay. Then other type of prevention, we can have control of admissions, invasive procedures, uh, keep sterile, hand washing, advised before touching any baby and between babies, more effective than gowning and masking. So this is part of the prevention measures. Then clinical features, we can have specific and non-specific clinical features. So non-specific features, we have the early signs of sepsis, which are often subtle and non-specific. Indeed, then high index of suspicion is needed for early diagnosis. So neonates with sepsis may present with one or more of the following symptoms and signs. So hypothermia or fever. So they can have both. They can either have hypothermia or fever. So former is more common in preterm low birth weight infants. Then the other symptom or sign is they can have lethargy, poor cry, and refusal to suck. Then C, poor perfusion, prolonged capillary refill time, hypotonia, absent neonatal reflexes, brady or tachycardia, respiratory distress, and apneic and gasping respirations. Then you can have hypo or hyperglycemia, and of course metabolic acidosis. So these are non-specific features. Then for specific features which are related to various systems, we can have from the CNS, we can have bulging anterior fontanelles, which could be a vacant stare, high-pitched cry, excess irritability, stupor or coma, seizures, neck retraction, and also presence of these features should raise a clinical suspicion of meningitis. Then under the CVS, we can have hypotension, pure perfusion, shock, and then in the GI, we can have feed intolerance, vomiting, diarrhea, abdominal distension, paralytic ileus, and also neck could be one of the necrotizing enterocolitis. Then under the hepatic system, we can have hepatomegaly, direct hyperbilirubinemia, especially with urinary tract infections. In the renal, we can have acute renal failure. The hematological, we can have bleeding, petechiae, papilla, skin changes, and multiple pustules, and abscess, scleroma, and motoring umbilical redness and discharge. These are some of the specific features. Then investigations, we can do a full septic screen or sepsis screen, where we can have blood or CSF or urine/stool for MCS. So for blood culture, which is the gold standard for diagnosis and should be performed prior starting antibiotics, and the positive blood culture sensitivity of the isolated organism is the best guide to antimicrobial therapy. Then urine culture have a low yield and are not indicated routinely. However, neonates at high risk of fungal sepsis as well, and with urogenital malformation or vesicouretal defects or suspected of UTI. So that's when we can use this urine culture. And then the other things which are helpful are FBC/DC, where we look at the HB and the platelet count, and of course there should be an immature band ratio of more than 0.2. Then you can have acute phase reactants such as CRP. Then of course you can also add DSR. Then others can do a chest x-ray. Okay, then under radiology, the chest x-ray should be considered in the presence of respiratory distress or apnea. Then an abdominal x-ray is indicated in the presence of abdominal signs suggestive of necrotizing enterocolitis. Then the other things we can do is a surface swab. Typically suggests possible exposure but may not point to offending pathogens. And then of course maternal vaginal swab, immunological studies such as antigen detection, antibody detection, more variable in viral infections. That's how it works. Then in case of meningitis, these are also indicated. You can also do an head ultrasonography in terms of if there is any ventriculitis, abnormal parenchymal encogenesis. Then you can have extracellular fluid, then chronic changes. You can have CT scan, obstructive hydrocephalus, cerebral infarction, abscesses, atrophy. These are some of the things which can happen. Okay, then interpretation of lab results. Then for the WBC or WBC/ESR, normal range at birth should be 10 to 30,000. This is when we are using cells per cubed meters, but this should vary with gestation age, and this value again should varies per lab, per lab. So for leukopenia, which is less than 5,000 per cubic meter, is significant and a strong indicator of sepsis. And ESR of more than 15 millimeters per HR is indicative of neonatal sepsis, though sensitivity is low. Then for CSF, normal WBC in the newborn, average of 6 per cubic millimeters, and range of 0 to 20, that's the range. Then CSF protein, we can have the term, which is 0.4 to 0.8 gram per liter, but this is for those who are term babies. Now for preterm can be as high as 1.2 gram per liter. That's for proteins. Okay, then neutropenia may be observed with maternal hypertension, severe perinatal asphyxia, periventricular or intraventricular hemorrhage, neutrophil ratios. So neutrophil immature band ratio or NIBR have been more useful in diagnosing neonatal sepsis. Then the maximum acceptable immature to take neutrophils for excluding sepsis in the first day is 0.16, with more than 0.2, which indicates if there is more than 0.2, it's going to indicate infection. Okay, then differential diagnosis for neonatal sepsis, we can have bowel obstruction in the newborn, birth asphyxia, congenital diaphragmatic hernia, congestive heart failure, congenital pneumonia, hemolytic disease of the newborn, meconium aspiration syndrome, necrotizing enterocolitis, pericarditis, pulmonary hyperplasia, and respiratory distress. Okay, then for treatment, types of medical interventions, we can have antimicrobial therapy, which is the main intervention, which is of course the main one, which is readily available. Then you can also have supportives. Then others which are we show no substantial clinical have been shown for these treatments are beneficial. We can have granulocyte transfusion, IV immunoglobulins, and IV immunoglobulin replacement, fresh frozen plasma, exchange transfusion, and the use of recombinant cytokines. So, for the antimicrobial therapy, knowledge of prevalence of organisms and antimicrobial susceptibility is very important, and you have to take specimens and start antibiotics. So this point is very important, because before you start your initial antibiotics, make sure you at least take the specimens, then initiate your empirical therapy. And you may need to change according to the susceptibility results, and of course the duration. The bloodstream infections 7 to 10 or 5 to 7 days after clinical response, but for meningitis, so the first duration is to can do the for 7 to 10 or 5 to 7, but for meningitis 14 to 21 days. And if it's gram positive more than 2 weeks, and gram negative 3 weeks after a negative repeat lumbar puncture. Okay, then these are some of the doses, but use them per protocol and per hospital, because they differ. Okay, for benzyl penicillin, which is X-pen, you can use 50,000 international units per kg per 24 hours in divided doses, or 100,000 per kg in 24 hours in meningitis, of course. Then, like I said, depending per hospital, because some they even go for 8,000. Then gentamicin, you can use 5 milligrams per kg per 24 hours in divided doses. Then you can also use 7.5 milligrams per kg per 24 hours in meningitis. Then cefotaxime 50 milligrams per kg per day, we increase to 200 milligrams per kg per day in divided dose, in 2 to 4 divided doses perinatally. Then ciprofloxacin, if you are using ciprofloxacin, you should use 5 to 10 milligrams per kg in 2 divided doses. Then others you can use fluoxacillin 50 milligrams per kg 2 times daily. Then you can also use 100 milligrams fluoxacillin per kg in meningitis. Then in suspected staphylococcus aureus, then of course fluconazole, if you are thinking it's fungal, you can use 6 milligrams per kg per 24 hours OD, like I said. Okay, then for supportive therapy, you have to remember the ABCs. Then you have to maintain nutrition. Then the general condition, your energy tube. In developed country, there is a parenteral nutrition. Then you have to ensure there is you maintain the glycemic levels of the patient to be normoglycemia, you good hydration, good perfusion, and you also monitor renal and liver function. You monitor bilirubin levels. Okay, that's the end of the tutorial, and thank you for watching, and see you next time.